It's okay, we are already online. Muy buenos días a todos los que nos acompañan el día de hoy en este cuarto día de Congreso. En nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, quien es Chairman of the World Congress, the World of Neurosurgery at Your Fingertips, a quien agradecemos enormemente la organización de este magno evento. Asimismo, agradecemos a la doctora Deyanira Capi Casillas, quien es Chairman del capítulo ANS-IPN, al Dr. Salim Abdul Raul, Chairman of Walter Erandi Neurosurgical Society, al Dr. Pavad Kateb, Chairman of the Society for Brain Mapping and Therapeutics, and the Brain Mapping Foundation. Además, agradecemos al Dr. Ives, Chairman, quien actualmente está como moderador en la sesión. También agradecemos al Dr. Guadarrama Ortiz, quien es Chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es así para mí un verdadero honor presentar la primera ponencia de este día, la cual estará a cargo del Dr. Charles Matouk, quien es vicepresidente del Departamento de Neurocirugía y jefe de la sección de cirugía neurovascular en Yale University and Yale New Haven Hospital.
Hello everyone. My name is Natalia Fedorchenko and I'm representing the organizing committee of the Congress. Today I would like to speak on behalf of the Jorge Herrera, Ambassador of Peace of UNESCO, ASPNet, the Chairman of the World Congress of Neuroscience, the World of Neurosurgery at your fingertips. We are happy to have all you here today, and thank you for joining us for the entire week. Thank you, Jorge Herrera, for creating this idea and organizing all this like really good. Today we have our moderator, Dr. Aipa Cherian, who is a director of neurosciences, Krishna Institute of Medical Sciences, Carotid, Maharashtra Consular General, Asian Congress of Neurological Surgeons, member WFNS Anatomy, Committee Associate Chief Editor, Surgical Neurology International, Head Trauma, Reviewer, World Neurosurgery Fountain, Cysterostomy. Dr. Aipa today will be a moderator for the talk of Dr. Charles Matouk, and also I would like to present our speaker, dear Dr. Charles Matouk, the Vice Chairman, Clinical Affairs, Department of Neurosurgery, Chief Section of Neurovascular Surgery, Yale University, Yale New Haven Hospital. Okay, Dr. Charles, can you start your talk now, please?
Yes, I'm going to share my screen, right? So let's see if I can do that. Can you guys see the talk? Yes, you can hear me? Yeah, perfect. So thanks everybody for the invitation to speak here today. It's a great honor. It's amazing how many people have signed up and registered for this event, and that it's going to be, I guess, available on different forums in perpetuity, which is actually quite, I think it's a great resource, for the worldwide clinical neuroscientist community. So today what I'm going to talk about is carotid revascularization strategies. And we're going to walk you through sort of what I think are main considerations from deciding who would benefit from a carotid revascularization procedure to some technical tips and tricks related to carotid endarterectomy and some of the other methods of opening up these stenotic blood vessels. Just in terms of disclosures, I'm a consultant for a company called Silk Road Medical, which is involved in carotid revascularization devices. And I'm a PI or a site PI or a sub-I for a number of enrolling carotid revascularization trials. So by means of outline, we're going to talk first about who should I revascularize. And we're going to talk mainly about the dichotomy between asymptomatic and symptomatic carotid disease and what that means. We'll then review what the options are for carotid revascularization. And then we'll go through an example and sort of highlight some of the evidence about, well, how I decide about these different methodologies. So when you think about stroke from a big picture, it's a very important cause of global morbidity and mortality. So in the United States, where I practice, stroke ranks 5th among all causes of death and is a leading cause of serious long-term disability. One of the big problems with stroke is that it takes you often out of the workforce. And so it's very impactful for families, and it's very impactful for economies, because folks are often, on the younger side, they're still in their working years. In 2013, when there was a large epidemiological study that was performed to sort of better assess global stroke burden, it turned out that it was the second leading cause of death worldwide, and the third most common cause of disability. So this is not a problem that's restricted to North America or to Western Europe, but is really global in its scope. Unfortunately, it looks like the epidemiological data shows a trend over the last 25 years that the stroke burden globally is increasing, and that it's projected to reach what are referred to as epidemic proportions in the next 20 to 30 years. When I'm old enough, hopefully not, but when I'm old enough to have a stroke. This is really the essence of what we're going to talk about today. So this is a carotid plaque that was resected at endarterectomy. Natalia, can you see my arrow on the screen or no? If I point out things, yeah?
It's yes, like, I see, yeah, all is good.
Perfect. So just to orient everybody, this end over here is the proximate end. So this is in the common carotid artery. This is the area of the bifurcation, and you can see actually where two vessels, this is the plaque that was sort of involving two blood vessels. Here, the internal carotid artery, which is the larger artery, a larger plaque here. And then you have this smaller remnant as a stub that was projecting into the external carotid artery. Here you can see the cut that I made down the middle of it, just sort of when I did the endarterectomy to get it out. And this here's the distal end. And this here's the distal end of the ECA plaque. So this is what a carotid plaque sort of looks like in real life. And we know that if we look at all strokes, that it accounts for about 15% of stroke worldwide, right? Because there's different stroke etiologies. You could have, for example, a cardioembolic source, for example, from atrial fibrillation. You could have a blood disorder where your blood is too thick or it clots. We sometimes see that in cancer patients. But carotid stenosis, this atheromatous disease that often involves the carotid bifurcation, accounts for about 15% of strokes. And so strategies to reduce the risk of having a stroke that's related to the carotid disease is obviously very important, and that's what carotid revascularization strategies represent. Now, when you look at a carotid stenosis clinically, the first thing that alerts you to this being a problem is imaging. And so either a CTA or an MRA or a carotid ultrasound. And what you're actually seeing there is a narrowing in the blood vessel, typically at the level of the carotid bifurcation. You just have to remember in the back of your heads, especially for the medical students, that carotid stenosis is typically from atheromatous disease. So the same disease that affects the blood vessels in your heart and your coronaries, or the blood vessels in your legs. But there are other reasons for having a stenotic blood vessel. And those are carotid webs, which is like this fibrous band that sometimes crosses the proximal internal carotid artery that you can see on imaging. It has a rather distinct appearance. And you can also have carotid dissections, which is a tear in the blood vessel. And that reduces the caliber of the true lumen. And then on the imaging studies, looks like a carotid stenosis, potentially. And so there are some different, I guess, signs on the imaging studies that might alert you to one of these other diagnoses. And that's important because it has different implications for the natural history of the disease and therefore its treatment. I'll also say that it's also very important to take a clinical history. And in particular, you want to ask for a history of radiation to the head and neck, especially as it relates to head and neck cancers, because that can cause accelerated atheromatous disease or a distinct entity called radiation-induced vasculopathy. And that, again, has a different natural history of treatment. So not all stenoses are equal. by far and away, the most important one is atheromatous disease. That's the common one. That's the one that we're going to be talking about today. But just remember, when you're looking at an imaging study, that in the back of your head, just remember that there are other reasons that you can have a stenosis on imaging that are not from atherosclerosis. Now, when we think about the carotid revascularization strategies, the sort of grandfather of all of these strategies is carotid endarterectomy. This is a time-honored, well-tested, evidence-based carotid revascularization procedure that has undoubted benefit in preventing strokes and in secondary stroke prevention. And I just want to go over some of that evidence, because I think it's important to understand what the relative benefit is for different indications, because that in part determines the energy that you're going to carry into the operating room. It's going to color the decisions you make about how aggressive you want to be in terms of accomplishing a carotid revascularization. And ultimately, that's going to be for the betterment of your patient. So many years ago now, in the 1980s and 1990s, there were 3 foundational trials that were conducted that compared best medical therapy at the time to carotid endarterectomy in patients that had symptomatic carotid disease. And in particular, what they were looking at in terms of what a symptom was the history of either what's called amaurosis fugax, which is painless monocular vision loss. That's thought to sort of be like a stroke to the eye. Or if a patient has a TIA, so a transient ischemic attack, which is like a stroke that sort of like resolves on its own in a short period of time, or a stroke that doesn't result in major disability. So if you had one of those 3 things, then you were labeled as having symptomatic carotid disease. The reason I'm taking the time to spell that out is that dizziness and lightheadedness and vertigo and all those other types of symptoms that folks come in with, those are not what were considered symptomatic in the trials. And so whether or not they're considered related to the carotid stenosis or not, that hypothesis was not tested in these trials, and therefore the benefit of carotid revascularization for those presenting symptoms remains uncertain. So really here what we're talking about is amaurosis fugax, so a stroke to the eye, a mini stroke or a TIA, or a stroke that hasn't caused severe disability. And if you came in with that and carotid disease, then you were randomized into these trials of either getting best medical therapy or a carotid endarterectomy, which is the surgery, and then you were followed over time. And the results from those 3 trials are now summarized in this graphic, which looks a little bit complicated, but again, I'm going to walk you through it. At the bottom of the graphic, you can see here where my arrow is pointing, it says stenosis. Now, let's see over here if I can I'm going to go to a laser pointer so it's easier to see. So there's the stenosis, right? And if we go over here, you can see as we move from left to right across the screen, there's increasing severities of stenosis. And what you have here on the y-axis is called the absolute risk reduction. You can think of it as benefit, right? So it's the absolute risk reduction of preventing an ischemic stroke on the same side as the carotid disease, or of having an operative or procedural stroke within 30 days of the procedure. And so there's different bins that you can see over here, right? So there's different bins of these 3 different columns. So you can see that for every sort of like bin of stenosis, so 70 to 79%, 80 to 89%. And what the 3 different columns represent is time from the event or from the endarterectomy. And you can see that's either going to be 3 years, or 5 years, or 8 years, right? So it just suggests benefit over time. So you can see over here that for the 90 to 99% stenosis, the benefit of carotid revascularization is very high. So it's much better than best medical therapy at preventing a stroke, even if you include the procedural strokes that are caused by the endarterectomy itself. And when you get into these lower grade stenosis, almost in a linear fashion, you see a reduction in benefit. So there's more benefit to revascularizing a symptomatic 90 to 99% stenosis than there is a 60 to 69% stenosis. And when the stenosis falls below 50%, you can see here that these standard deviations cross the 0 line. And what that means is that benefit is not certain, right? And in fact, for the lowest grade stenosis, less than 30%, it was found to potentially be harmful, carotid endarterectomy. And so this here establishes, I think, really the best evidence almost for any surgical procedure on the planet, you know, including appendectomy and cholecystectomy and any type of intervention for anything in medicine. This represents one of the best, highest levels of evidence that a procedure is beneficial to the patient at doing what it's supposed to do. So when a patient comes in with a high-grade stenosis, so greater than 50%, and they have a symptomatic carotid, and we discussed what symptomatic carotid means, there is clear benefit to performing a carotid endarterectomy. And to have a number in your head about how many people do you have to treat to prevent one stroke, that's captured in this concept of NNT, or number needed to treat. The number needed to treat is only 6. So you have to treat 6 people to prevent one stroke after a carotid endarterectomy. So that's very beneficial procedure on the scale of things that we do for a living. If you look at medications, you may have to treat hundreds of people to get one good outcome by taking a pill. So this is actually a very impactful procedure for people to have. And again, the benefit is reduced as the percentage stenosis is reduced. Another important thing that I want to highlight, again, for the medical students in particular, is that it makes a difference when you operate on the patient. We tend not to like to operate within 48 hours of a presenting stroke or stroke-like symptom. But if you operate more than 2 weeks from the ictal event, then the benefit of that carotid revascularization procedure falls precipitously. So again, if you look at this meta-analysis of those big trials, you can see here on the x-axis, there are bins in 0 to 2 weeks, 2 to 4 weeks, 4 to 12 weeks from the stroke presentation. And here again, you have on the y-axis benefit, that the benefit falls whether you have a high-grade stenosis or a moderate stenosis, the longer out you go from the stroke. And in fact, once you get after a month, it's not clear that a patient will benefit from a carotid revascularization procedure. The reason this is important is that when you're seeing a patient in the clinic and they had a stroke 6 months ago and they have a carotid stenosis, you know that your intervention is going to be much less effective at preventing stroke in the future than had it been done in the 2-week interval immediately after the stroke. And so that is going to color your decision-making about how aggressive you want to be at performing a difficult carotid revascularization procedure. Again, the only reason we do any of these things is to prevent strokes. So if it's not going to achieve its stated aim, you have to be more deliberate and cautious, I think, in your approach to whether or not that patient should be revascularized. So we've talked about symptomatic carotids, and I want to go now to the other end of the spectrum, which is asymptomatic carotids. So these are patients that might have, got into their cardiologist's office and they have chest pain, and during the workup of their chest pain, a carotid ultrasound was done and they found a high-grade carotid stenosis, or a patient slipped and fell and they got, in the US, everybody gets tons of imaging. I'm sure it's the same in many places around the world. And, an incidental carotid stenosis is picked up after a fall. And now you have to sort of deal with this carotid stenosis, or an internal medicine doctor auscultates a bruit over the patient's neck, and that leads to a Doppler examination. And you have now an asymptomatic carotid stenosis. So again, a carotid stenosis that hasn't caused a stroke. This has been also looked at in multiple trials. And what this graph basically shows is the recruitment period into these different trials over time. So this here is not when the study was published. So here on the x-axis, you can see different years, but the time period during which the subjects were recruited into the different trials, and the acronyms of those trials are named above in the figure. And what you have here on the y-axis is the average annual risk rate of stroke. And what you can see is that over time, there has been a decrease, right, in the natural history arm of asymptomatic carotid disease. So what that means is that if you were in 1985, right, your risk of having a stroke from an ipsilateral carotid stenosis was about 2% per year. That's what this sort of mid part of the graph is. But if you look at the OXVASC study, which looked at patients more recently in the 2000s, the risk of having a stroke from ipsilateral carotid disease was very much less. It was only 0.34%. Now, the patients in the OXVASC study, or the people that were being observed in that study, were very closely monitored, and they were, exercising and eating right, and they were on aspirin, and all those things that we think are important. Nowadays, they would be on a statin medication as well. There's no question that medical therapy and risk factor modification reduces your risk of having a stroke in patients with asymptomatic carotid disease. In fact, there are nice papers now that show that prolonged use of statin medications can actually induce radiographic regression of plaque, which is amazing, but is sort of the objective evidence that these medical interventions are impactful in terms of the natural history of people's disease. The reason this is important, again, is that if your risk of having a stroke is 2% per year from an ipsilateral carotid stenosis, then there is some benefit to carotid revascularization in terms of primary stroke prevention, right? Because these folks haven't had a stroke yet. But if your risk of having a stroke is only 0.34% per year related to the carotid stenosis, it's very hard to do anything with that lower risk profile, let alone carotid surgery. So I think that when you're thinking about asymptomatic carotid disease, even if the risk is relatively high in the 2% per year range, the number needed to treat is more like 19 to prevent one stroke in a 10-year period of time, as opposed to for symptomatic carotid disease, where the number needed to treat was closer to 6 over a 2-year period of time. So it's a very much big difference in terms of the benefit of stroke prevention related to the endarterectomy. Now, I caught a little bit of Dr. Hernasmiani's talk earlier in the week, and I agree with him completely. Again, one of the fathers of our field, and he stated that medicine is very much and surgery is very much an art, and I do agree with that entirely. I think that we have to look at the evidence and know the evidence very well. But at the end of the day, people don't fit into different clinical trials, and we have to develop an impression that's based on experience and our interpretation of the evidence. And one of the areas that's emerging is this concept of the high-risk plaque with a low percentage stenosis. So up to now, the field has really been stuck in this concept of that it's the percentage stenosis that's the most important dichotomizer when thinking about carotid disease. So you have to have a greater than 50% carotid stenosis to have shown benefit in these trials. I don't think that's true, and I think that many people now are sort of like warming up to this concept that has been pushed by some thought leaders in the field, including the folks at Johns Hopkins and in Baltimore in the US. And what they sort of talk about is that you can very much have, if you look over here at the figure, the same percentage stenosis across this graphic, but they have different amounts of plaque. So for example, this patient has a lot of plaque and a 50% stenosis, whereas this person has a little bit of plaque and a 50% stenosis. Well, I think that their risk is different. right? And that's turning out to be true. And even if you have a small amount of plaque, you could have a high risk feature within the plaque, like an ulceration or a defect in the lining of the plaque, such that some of its toxic content, like the lipid that forms the atheromatous center, or hemorrhage within the plaque, is exposed to the lumen, and that can lead to platelet aggregation and clot formation. So this is the idea now of the vulnerable plaque. And so these are plaques where the percentage stenosis may be a less important indicator than plaque morphology. There's an ulcer, the vulnerable plaque. So again, over here, you can see in this cross section from a review from the group at Johns Hopkins that you can have hemorrhage into the wall of the carotid artery or into the plaque, and that this intraplaque hemorrhage is a very important indicator of future stroke risk, independent of the percentage stenosis. And so here on this sort of like advanced imaging sequence, you can see here that there is clearly a carotid stenosis, but when you use this technique to look at the amount of hemorrhage in the wall of the plaque, you can see that all of this bright stuff is blood product. This hemorrhage, even though it's related to a percentage stenosis that we may or may not intervene on, in a patient that may or may not be symptomatic, that this intraplaque hemorrhage portends, it predicts future strokes, even more so than the degree of stenosis. And so this is from a case that was recently in my practice, an unusual case, but I'll show it anyways, in which a patient had a very elongated styloid process. It's that sort of bony thing that juts out from the base of your skull, like an icicle. And you can see here, it's so long that it's actually pushing into the carotid bifurcation. And this is a patient that presented with recurrent strokes and had this less than 50%, right? Nearly free-floating thrombus. And every time she had a stroke, she would have exactly this picture, and then this would go away over time on a heparin drip. So the next time that it happened, we said, well, we can't keep watching this happen. There must be something there. And in fact, and it probably something that was induced by this elongated carotid, you could see like a small ulcer in the wall of the carotid artery with a superimposed little piece of hemorrhage that we were able to then remove, and then remove, this is my finger on the styloid process, remove the styloid process as well. This is a tendon that's attached to the tip of the styloid process that we can cut and then detach this over here from the skull base. But the idea here is, again, that this is a patient that wouldn't have met traditional carotid revascularization evidence, right? But medicine has to be, and surgery has to be also an art where we use our experience and our understanding of what we think pathologically is happening or pathophysiologically is happening to make judgments for our patients, right? And that's how risky we want to be, how much risk we're willing to accept. Has to be informed in part by the evidence, but also by those experiences. So this is an emerging concept. And so for the junior practitioners and the medical students in the audience, you know, the first thing you want to ask yourself when you see a patient with a carotid stenosis is this patient asymptomatic or are they symptomatic? And we reviewed what that means. It doesn't mean, is it related to the carotid, right? So it doesn't mean lightheadedness, vertigo, any of the fainting spells. Those things may or may not be related to the carotid disease, but that is not what was studied in the trials, right? So it's amaurosis fugax, it's a mini stroke or a TIA, a non-disabling stroke. Once you answer that question, asymptomatic, symptomatic, then you can divide yourself very nicely into two different sort of algorithms. In an asymptomatic patient, be careful when you're beginning your practice, right? That may be of benefit, right, to the patient to have the revascularization done. It'll be more impactful in younger patients. It turns out that the evidence would suggest that it's more impactful in men than women. It turns out that maybe you should be looking for some high-risk features, and we talked about what some of those might look like on the imaging studies. But be careful, because the number needed to treat is not nearly as low, right? There's not as much benefit as there is for intervening on a symptomatic carotid stenosis. So you don't want to adopt a lot of risk, especially if you think the procedure is going to be technically difficult. When you're thinking about symptomatic carotid disease, the big dichotomy is, again, is the patient have a greater than 50% or a less than 50% stenosis? You are on solid ground if you have a patient that has a greater than 50% symptomatic carotid stenosis in terms of the evidence to revascularize. So you can feel very comfortable about accepting more risk because there's a lot of benefit to gain. And then in terms of less than 50%, there will be times when that is appropriate, but that really has to be, that is part of the now art of medicine as opposed to the evidence. And it's an emerging concept. And again, here I would look for these high risk plaque features. All right, that is actually the most important thing I'm going to say, I think, in this talk, because really the best way to avoid a complication is to intervene with the correct indication, right? If you embark on a surgery that isn't indicated, it's all risk and no benefit. All risk and no benefit. So what we talked about in point number 1 will actually keep you out of trouble more than anything else I'm going to talk about next. Okay, what are the options? So there's 3 nowadays. One is carotid endarterectomy. The other is carotid angioplasty and stenting. And the third is a hybrid open endovascular technique called TCAR, or transcarotid artery revascularization. And here it's illustrated in this little figure from the company. Education's a funny thing nowadays because we have, like this forum, so many resources that you can draw on. So even if you don't have a surgeon performing carotid revascularizations at a high rate where you're training, there are so many videos now and books available on how to do the procedure that you really have the opportunity to teach yourself. And that wasn't true, right, a few years ago, even when it was much more an apprenticeship, where you had to travel somewhere and spend time with somebody, which I still think is extremely valuable. But you would have no exposure to it otherwise, because there wasn't all this wealth of sort of like resources. And when I was training, we did have a good carotid. We had wonderful carotid surgeons where I trained. Bill Tucker was one who enrolled people in NASA. Chris Wallace, who was my program director at the University of Toronto in Canada. And Mahmoud Fazal, who was just this wonderful technical surgeon and human being, really, that I learned a ton from, especially as it relates to carotid surgery. But I just highlight this book in particular because I've never met Chris Loftus. I think he works at the University of Temple in Philadelphia. But this textbook was a book that was in the resident library where I trained. And I must have read this book something like a dozen times. It is a beautiful description of the variations and technical details that are related to carotid endarterectomy. And really the technique that my practice has evolved into, and now I've performed, I think close to over 400 carotid revascularization procedures in total. My technique is essentially a modification of his, a guy that I've never met, but whose book I've read, probably again a dozen times. So what's illustrated over here in the top is how to position the patient. You want the patient's head to be slightly extended. I often put a roll directly under the shoulders so that the shoulders sort of fall off the roll. You want to make sure that the head is supported. So that might mean that you might have to put some blankets underneath the head. If you put your finger on the sternal notch and you put your finger on the bony prominence behind your ear, right, then that line that you draw will be the anterior border of the sternocleidomastoid muscle and its 2 bony attachments. And what I always also indicate is the angle of the jaw. You want to make sure that your incision does not cross the angle of the jaw, but is quite a bit more lateral from it. So that's a useful landmark when you're planning your surgery about where you want the incision to go. And then the angle of the jaw will often point to about the level of the carotid bifurcation. So that'll give you a sense of how big to make your incision, depending on how high or low your carotid bifurcation is. We then cut the skin, and the first layer that you're going to go through is some soft tissue and fat, and then you'll get to the platysma, which cuts very easily with a 10 blade. And once you cut the platysma, what you'll see is this muscle over here, which is the anterior border of the sternocleidomastoid muscle, and that's your friend. And you're going to dissect just in an avascular plane along this sternocleidomastoid muscle, and then you're going to reflect it, and you're going to see this areolar tissue. This areolar tissue, now you have to take a deep breath, and you have to have a little bit of faith, and you have to cut through it. And when you do that, what you're going to see revealed is the internal jugular vein. And it's very blue, and it's very classic looking, and you can't mistake it. And what you want to do is you want to get on its medial border, because you're going to pull the internal jugular vein laterally. Now, what's going to prevent you from pulling it laterally is that it's tethered medially by some veins, the biggest of which is the common facial vein. And these can be isolated and divided and allow you to pull then or retract the internal jugular vein laterally, thereby exposing the common carotid artery, which will be right next to it and underneath. So that's the essence of the exposure to get to this point of the operation, which is the carotid tree. You only have to dissect along the medial border of the internal jugular vein. You don't need to dissect along the lateral border, again, because the idea is just that you're going to mobilize the vessel laterally to expose the carotid tree. The next thing that you're going to do is you're trying to be sensitive to not disrupt the plaque too much. So you want to work sort of above and below the plaque as much as possible. And you can often palpate the plaque and see it visually in the carotid artery. It will look different, even externally when you're looking at the carotid tree, at surgery. But you want to first get vascular control, which is to go around the common carotid artery over here. You have to be careful when you put your vessel loops on not to encircle the vagus nerve, which often runs in between and below these structures. And then you want to isolate the internal carotid artery above the carotid plaque, and you want to isolate the external carotid artery over here. I'm pointing at the wrong figure. This is the carotid tree over here. This is the common facial vein that's being divided. So the first branch of the external carotid artery also has to be secured. That's the superior thyroid artery. And so now you have like loops basically around all these different vessels: the common carotid, the internal carotid above the plaque, the external carotid artery trunk, and the superior thyroid artery. One of the tricks that I learned from Chris Wallace, so this is like now going back more than a decade, but I still use every day and I remember well, is the technique of what they call it excluding the internal carotid artery. So one of the branches of the external carotid artery, the second branch, in fact, after the superior thyroid artery, is the ascending pharyngeal artery. And the ascending pharyngeal artery runs posterior to the internal carotid artery and runs parallel to the ICA, almost up to the level of the skull base. And so it's very easy if you just put a vessel loop around the external carotid artery to not include the ascending pharyngeal artery. And so when you go to perform and you have all your clamps on, you go to start your endarterectomy and make your incision with your knife, you'll get robust arterial bleeding because you haven't secured the ascending pharyngeal artery, which is a nuisance because then you have to take all the clamps off and get, vascular control. So the way that he taught me to do this, which again I still use today, is this technique called excluding the internal carotid artery. So you're going to put your like a right angle clamp like this under the entire carotid bifurcation. Okay, so it's going to come all the way under both carotid arteries, and you're going to pass a vessel loop. So you're going to go from one side to the other side of the carotid bifurcation. And then you're going to come in here in the crotch between the ECA and the ICA, right, with your right angle clamp, your right angle instrument. And you're going to pull the vascular loop behind the internal carotid artery and pull it up in the clamp. So you basically removed the internal carotid artery from what's within the loop. So now you have, by definition, all the branches of the external carotid artery in your vascular loop. And you have now control of the ascending pharyngeal. So that method is called excluding the internal carotid artery, and it will save you a lot of grief in terms of missing the ascending pharyngeal artery when you're going on cross-clamp. This next photomicrograph basically shows another important structure that we have to worry about a lot during carotid surgery, which is the hypoglossal nerve, and that's the nerve to the 12th cranial nerve. And there's some very important relationships that you're going to see here in this figure. It's often when you're getting started with carotid surgery and you don't know what this looks like, everything looks like the hypoglossal nerve. But the hypoglossal nerve is actually quite large and it has a significant structure to it. I'm going to show you some pictures in a minute. And so, you know, you'll be able to see it and recognize it over time as being that particular structure. But it has a very preserved course. The first thing to remember, again, for the medical students and junior residents, is that the hypoglossal nerve innervates the tongue. And so it courses from a medial location over the carotid bifurcation, typically about 1 centimeter above the bifurcation, and then turns sharply, it always does this, to follow the internal carotid artery in the chute. Okay, so that's how this works over here. The reason this is important is that if you're having trouble finding the hypoglossal nerve as you go distal in your dissection, which you want to identify clearly so that you don't injure it, the best way not to injure something is to see it, is that don't dissect medially, dissect laterally, right? Because the hypoglossal nerve goes from medial and then will course up along the internal carotid artery toward the skull base. It will not be in this lateral location. So this is a safe place to start dissecting, to find the digastric. The digastric will be a very useful border because the hypoglossal nerve is beneath that. So this is like a safe zone, whereas this here is a dangerous zone in terms of protecting the hypoglossal nerve. So what we see now over here is what it looks like sort of in real life. And so here you have proximally the common carotid artery. You can see here, there's like a clear, area that's different where the atheromatous disease ends, and then it becomes softer over here. Here's the external carotid artery, its first branch, the superior thyroid, and here's the very distinct appearance of this hypoglossal nerve, originating from medially, crossing the carotid bifurcation about 1 centimeter above the bifurcation itself, and then coursing under the digastric along the ICA up towards the skull base. So it has a very distinct and robust sort of like look to it. Every little thing that you see is not the hypoglossal nerve when you get started. That'll be a learning curve that you'll have to sort of overcome. In terms of how to clamp the different vessels, the acronym ICE is very helpful. So you do first the internal, then the common carotid, then the external carotid. So you're protecting the brain is the idea. So protect the brain first by clamping the internal, then you do the common and the external as well as the superior thyroid artery. And then you can start your endarterectomy. Usually start with a number 11 blade, extend the incision with the pot scissors. And here you can see that in this particular case, this fresh thrombus from the symptomatic carotid just bubbled out of the endarterectomy site. You can then use a dissector to remove the atheromatous tissue from the ECA, the ICA. And here you can see this very nice, clean luminal surface of the vessel. You can shunt or not shunt depending on whether or not the patient's having new neurological deficits or electrophysiological changes during the procedure. I tend to shunt selectively, so only when needed, which is rare, I would say about 5% of the time. And then you can do a patch or not patch the vessel. A patch means that you place a little piece of material to enlarge the vessel lumen. I tend not to do that in men. I tend to do that occasionally in women, especially if their blood vessels are small. But either method is totally acceptable. And here in this view, again, you can see very nicely this hypoglossal nerve that's crossing about 1 centimeter or more above the bifurcation. This is the typical appearance of a symptomatic carotid plaque with this fresh, angry-looking hemorrhagic lesion. Now, I just want to pay a little bit of special attention to what I think the most important technical element related to carotid surgery is, which is removing the plaque from the distal end of the endarterectomy site. If you think about this vessel as your endarterectomy site and your carotid, and here you have distally a little bit of vessel wall or plaque that's left. If you dissect with your instrument underneath that vessel, that remaining plaque, which you're not going to remove, or you don't want to remove, or a little bit of vessel wall, abnormal vessel wall, and isolate that from the main vessel wall, this little area then is going to fill with blood when the blood vessel is reopened. Here's the direction of blood flow. The direction of blood will then basically lift off this little dissection flap, which is what it is, and it will crush or limit the lumen of the vessel from the inside, right? So you're basically raising this dissection flap, which will constrict the true lumen of the vessel, which will now be very small. This will result then in the patient having an occluded carotid artery, and that is potentially a devastating complication that will result in a bad stroke. And so the distal end of this endarterectomy either has to feather out very nicely, so there's no dissection ledge, we're talking about right over here, or if there is a dissection ledge, then you have to tack it down with some 6-O-Prolene or some other type of suture with a knot on the back wall of the vessel, so that it's not going to lift up like this and occlude the lumen of the vessel when blood flow is restored in this antegrade direction from proximal to distal. I think that this is the biggest potential bad complication that can arise from surgery. The acronym ICE is also useful, by the way, in terms of how you remove your cross clamps at the end of the procedure. You want to go in the reverse order, so external comes off first, then the common. The reason that you do this is that you've now restored antegrade flow into the external circulation. I allow 8 heartbeats to pass. That will hopefully wash out the internal carotid artery lumen, and then you can release the internal carotid artery cross clamp and restore blood flow to the brain in that way. All right, so now we're going to go on, I think, to very briefly discuss carotid angioplasty and stenting. Now, you don't have to do this procedure to understand, you have to understand it enough to understand like what the limitations of the procedure are, what the advantages of the procedure are. One of the very nice advantages of this procedure is that it's very straightforward, it's very quick, and the patient basically can go home later the same day or the next day. It's a very minimally invasive procedure that's performed through your groin or through your wrist. It basically involves these following steps. That you go, in this case, we went through the groin, you put up a long sheath into the common carotid artery. You can see here the level of the stenosis. Now you have to cross the stenosis once unprotected with a micro guide wire. And here's, you can see the wire. And on the end of this wire is this basket. And here you can see this basket over here. This is the basket. A basket will be deployed distal to the lesion. You can then use this balloon and stent to open up the stenosis, right? So now you have a nice caliber blood vessel. The idea being that any debris, right, that was dislodged during the balloon angioplasty is going to be caught in this basket that can then be retrieved. So that's the concept of carotid angioplasty and stenting with distal protection. The problem with the procedure, and we're going to get into this a little bit more in a second, the problem with the procedure is that the distal protection device is not very effective. So in this very high quality study, there's about 3 times more patients in the stenting group than in the endarterectomy group that had new ischemic lesions on MRI after a stenting procedure versus an endarterectomy. And that's because the procedure is inefficient, right? The protection strategy is not an efficient one. And especially for symptomatic carotid stenosis, where you saw that friable hemorrhagic plaque, it can easily be dislodged and then not captured in the basket effectively, or the basket spills when you're trying to retrieve it and releases the embolic material into the brain, causing a stroke. So the last procedure, which is the newest of these carotid revascularization procedures, is the TCAR procedure. And it's a hybrid open endovascular procedure that I'm very fond of, that involves a very small open incision just above the clavicle. to expose the common carotid artery well below the bifurcation. You then isolate the carotid artery surgically, and then you, using a micropuncture technique, insert a sheath into the carotid artery itself after gaining proximal control of the vessel. You can then attach this arterial sheath that's in the common carotid artery to a common femoral vein in the leg and create an arterial venous shunt. So now you have a shunt where you're basically going from high arterial blood flow to low venous blood flow. And in the middle of that circuit, there is a filter. And so when you clamp the carotid artery and you turn the AV shunt on with the filter in the middle of the circuit, you essentially are reversing blood flow in the carotid artery. And so now you can perform an angioplasty and stenting procedure without having to cross the lesion unprotected, one of the major disadvantages of transfemoral carotid angioplasty and stenting. It also obviates having to navigate the arch, which in older people can be quite difficult. So this is what this procedure looks like. This looks like a huge incision, but it's actually a very small incision that's located just on the superior border of the clavicle. You can then see the two heads of the sternocleidomastoid muscle. If you dissect in that region, and just like an endarterectomy, if you pull the internal jugular vein lateral, you'll see the common carotid artery that gets cannulated, attached to this venous sheath via the circuit. You create your AV shunt, and now you can perform the angioplasty and stenting procedure under proximal, basically under flow reversal in the carotid artery, right? So it's now all moving away from the brain. So the debris is going into the circuit, and hopefully debris is getting caught in the filter. So to end with, we're going to talk a little bit about how I choose. Carotid endarterectomy is not going anywhere in the near future. It is, again, this time-honored procedure that I think is extremely robust and is the gold standard by which any procedure has to be measured. This was a very elegant review where they looked at the major trials that compared endarterectomy versus carotid stenting for symptomatic carotid disease and showed in a fascinating way that for carotid disease, which is the right side of this chart, between 2000 and 2008, surgeons got better. You know, as they did more procedures, their stroke rate fell from 7.1% to 2%, whereas the transfemoral carotid angioplasty stenting group did not have a significant improvement over time, suggesting that it's a limitation of the strategy, right, as opposed to a limitation of the proceduralist. So again, here, the major problem being, you can see here that the risk of having a stroke is higher than in the endarterectomy group, which is really the big problem with transfemoral stenting. And so in my practice, I typically reserve transfemoral stenting only for patients that are deemed higher prohibitive risk for carotid endarterectomy. Just to quickly go through this newer procedure, TCAR, the evidence is slowly growing and it's becoming very strong. And you sort of can't ignore it completely. But the reports now from both the pivotal studies, as well as now large registry studies, which are illustrated here, suggest that the TCAR procedure, this hybrid open endovascular procedure, is safer than stenting in terms of stroke risk, probably 2 times safer in terms of stroke risk, and is becoming more and more comparable to carotid endarterectomy. And that probably has to do with the much lower rate of embolic hits, like we talked about earlier, that you see in TCAR versus the transfemoral carotid angioplasty and stenting procedures. And if you look at my practice over time, you can see that my use of carotid stenting has steadily fallen, and my use of endarterectomy and TCAR has increased. If we go to 2020, the TCAR and the CEA lines are now matched, and the carotid stenting line is even lower. Maybe for the sake of time, I'm going to stop here. I was going to go through a case, and this case will be available to you if you want, and I think it's well illustrated. But it basically goes through my thought process relating to all the different aspects that you should look at when deciding about, once you decide that you're going to do a carotid revascularization, how do you decide between the different methods? And that often has to do with, if is the lesion a stenting lesion or not. If there's a lot of calcium in the lesion that's circumferential and thick, then it's not suitable for any stenting. And so you really fall into the endarterectomy group. After that, the decision becomes a little bit more complicated and has to do with access, medialization of the internal carotid artery, medical risk factors, depending on how high a cardiac risk the patient is, with CEA being a little bit harsher on the heart. And I'm going to stop, I think, there, and just say that we talked about the evidence and how to think about who to revascularize. And the idea is that the best way to prevent a complication is to operate with proper indications. And then the next thing is understanding what the three options are for carotid revascularization: CEA, transfemoral CAS, and TCAR. And then a little bit about how I choose, which is in part based on very good evidence and in part based on emerging evidence, as well as the art of medicine and how you interpret it in your practice. Thanks again for the opportunity to talk, guys.
Thank you so much, Dr. Charles Matouk. I'm sorry I missed introducing you. I was giving another lecture at the same time, but it's great to have you with us. That was a beautiful presentation. It's very comprehensive for us to understand this. I remember my days at Yale New Haven Hospital very fondly. So it's great to have you with us and to share with your experience with us. Thank you so much.
Thank you.
Yeah, and I want to, we have a couple of questions, Dr. Matouk. I just wanted to kind of summarize a couple of questions into one. One of our neurosurgeons is asking the question, what is your view and recommendation for complete carotid occlusion? How do you look at that?
It's a great question. I think it had, our concepts have emerged slightly into whether or not the occlusion is very acute and causing an emerging stroke, or whether the patient comes in with a stroke that's now a few days old and has a carotid occlusion, or presents with symptoms related to a chronic occlusion. That differentiation, I think, of like how the patient comes to your attention really becomes very important in how you think about it. With the emergence of stroke therapies that we're doing emergently, we will often, if a patient has a developing and evolving stroke, we will often, especially if there's an intracranial occlusion, we will open up those occluded carotids to get the intracranial occlusion, and then deal with the stenosis that's left either acutely, interventionally, or bring them to surgery afterwards. If a patient has a chronic occlusion and new symptoms, then we usually don't intervene surgically. Those patients are often stabilized on a heparin drip. And I think you'd have to be forced into doing a procedure to revascularize an occluded carotid, especially if it's chronic. Having said that, David Hassan at the University of Iowa is leading a small NIH-funded study specifically to look at the benefit of revascularizing chronic carotid occlusions. And so the story is not completely out, but if you remember one of the slides I presented initially about the NASIT data and the foundational CEA trials, the string sign or the carotid occlusion did not have significant benefit after revascularization in those foundational studies. So they're not perfect, and the story is still in evolution, but I wouldn't open up every carotid occlusion that I see. How do you feel?
Well, no, thank you. No, I fully agree with everything you said. For the chronic occlusions that are symptomatic, those of us who are, have been involved with ECIC bypass trials, we were a little disappointed by some of the data. We were a little, because there was a subset of patients who benefited from ECIC bypass in a very, very fine set of criteria. I think, at least it's my belief, and I would love to have your insight, in experienced hands, do you think for chronic occlusion, somebody who's having hemodynamic kind of symptoms, is there a role for STA-MCA bypass?
I think there certainly is. And like you said, I think that the indications have to be correct. The ECIC trials were extremely disappointing, and I think did a disservice to bypass surgery sort of nationally. But there's no question that clinically at the bedside, if you take care of patients, it's very difficult to see somebody sort of have progressive strokes due to malperfusion that's objectively demonstrated using, a cerebrovascular reserve study. It's hard, you're hard pressed to sort of just completely ignore that. And again, I think there's going to be a resurgence of bypass for some of these indications as we understand the indications better.
Right.
Yeah.
Well, Charles, it's been a great presentation, educational, just a very comprehensive. We thank you so much for it. And please give my greetings to all of our colleagues at Yale. Okay, thank you.
Yeah, Dr. Charles, thank you very much for the presentation. It's really good. A lot of cases. Thank you for accepting the invitation for the Congress. Thank you very much. Thank you to the organizing committee, to the Jorge Herrera, the vice chairman of the Congress, ambassador of peace, to create all this to gather us together today. And thank you for your talk.
Wonderful. I have to say that we have one of your pupils at Yale now who's been wonderful, Nanthia Suji Juntara.
Oh yeah, Nanthia was my medical student. Now she's one of your residents, and I'm glad to hear she's doing well, huh?
Doing very well.
Great.
Doing very well.
Yeah.
All right.
Well, I'm very proud. I'm very proud to hear that, Charles, and I look forward to catching up with you sometime offline as well. Thank you so much.